Good evening, friends, and welcome back to the Thursday evening teaching session brought to you from Sion Hospital, Mumbai. We once again thank the head of the department, Dr. Radha Gildial, and the Dean of Sion Hospital for allowing us to conduct these classes here, and also to Aristo Pharma for an educational grant which allows us a live webcast of these classes. Again, we have two cases today. The first one is being presented by Dr. Shiv Prasad from Sion Hospital.
Good evening, all. Myself, Dr. Shuprat Radne from Sion Hospital. A 3-year-old girl, fourth by born out of a third-degree consanguineous marriage, who is a resident of Mumbai, Muslim by religion, informant being aunt, who is reliable with the cheap complaints of swelling around eyes, noticed since 4 days, with decreased urine output for 4 days. The child was apparently normal 4 days back when she developed swelling around eyes, which is insidious in onset, progressed to face and not associated with pain for 4 days, which is more in the morning and gradually decreases as the day progresses. The periorbital puffiness was more prominent, with decrease in output for 4 days, which is 2 times per day, small in volume, which is not high colored. On negative history, there is no history of any fever, skin rash, joint pain, or sore throat. No history of any increased frequency of urination with dysuria or hematuria. No history of breathlessness, cough, or pedal edema. There is no history of any jaundice, high colored urine, hematemesis, or blood transfusion. And there is no history of any not gaining weight associated with any skin changes. And there is no history of any drug intake before onset of edema or insect bite. In past history, there is history of similar episode in the past. At 2 years of age, she had a similar complaints of periorbital puffiness, which is insidious in onset, progressive, not associated with pain, which is followed by abdominal distension and swelling of legs. Associated with complaints of cough and cold for 3 to 4 days, required hospitalization. Some blood and urine investigation were done, and child started on IV medication. After discharge, child received some oral medication for 6 weeks, around 6 weeks. And again, at 2 years and 7 months age, a child had a similar complaints with periorbital swelling associated with fever and pain while micturition. Again, blood and urine investigation has been done and started on IV medication. And after discharge, she received oral medication for 12 weeks. Between these episodes, child was asymptomatic. On antenatal history, the spontaneous conception with booked and immunized, who took iron and folic acid supplements regularly. No history of any fever with rash, oligohydramnias. ANC scans were done, told to be normal, and no antenatal complication were observed. On birth history, the full term normal vaginal delivery, birth weight of 2.75 kg, cried immediately after birth, and breastfed within 1 hour of birth. With postnatal history of no history of any NICU admission, no history of neonatal hyperbilirubinemia, no history of neonatal seizure, and the birth vaccine were received. On immunization history, appropriately immunized for the age according to the national immunization schedule. Last vaccination was given at 2 years of age, and there is no optional vaccines were given. On developmental history, the gross motor, he achieved all appropriate milestone for the age, that is head control at 3 months, sit with support 6 months, stand with supports 10 months, walk with the supports 11 months, and runs 2 years, climbs ups and down stairs 2.5 years. The fine motor pincer grasp achieved at 9 months of age and draws line by 3 years. Language 3 word sentence by 2 years, and socially knows gender. On diet history, child consumes 850 kilocalorie against an expected requirement of 1200 kilocalorie and 18 grams of protein, which meets the daily requirement. On family history, there is no history of any renal disorder, renal stones, hypertension, and diabetic mellitus in the family.
Wait, we'll just discuss the history. Okay, so We've discussed this many times. So, based on just this presenting history, what are your thoughts? What could be the possibilities?
Initial presentation being swelling around eyes since last 4 days with decreased urine output. Somewhere child has complained with renal system being involved prominently.
So, as usual, we ask you, why is this not cardiac, or why is this not malnutrition, or why is this not liver disease? What's your answer? Or can it be? Can it be liver disease? Can it be cardiac? Can it be malnutrition? Can it be protein losing enteropathy?
Since swelling is noticed by parents and it is periorbital swelling, so more towards renal origin, as if swelling is of hepatic origin, then child will have presentation like ascites, and if there is cardiac etiology, then maybe pedal edema as pedal edema ascites rather than periorbital swelling as a first presentation. In nutritional edema also there will be bilateral. Overall anasaka presentation involving bilateral plus all over swelling.
So we've discussed this many times, but we want you to understand that why do we say that renal edema is all periorbital, or why do we say periorbital is always renal? Why liver can't be periorbital, or why heart can't be periorbital, or can it be? That's the thing to understand. So what is the reason, or what is the discussion?
Periorbital puffiness just indicates the how rapidly the fluid accumulation has occurred. So it goes to the place where there is loose connective tissue, that is periorbital region.
So would an acute liver or an acute cardiac disease be considered? You said acute, rapid onset. I have a rapid onset cardiac or a liver disease. Would it be doing the same? You're right, rapid. But a rapid could be cardiac or hepatic. Nutrition can't be. Okay. So what's your comment on that? You're right. But let's understand what that rapid means. What do you think? Acute cardiac, acute liver. Will it not come with periorbital edema? Acute. So you must understand why acute renal comes but not others. Give a thought. Doesn't matter. Okay. We are teaching you how to think. The rest is all from the books. Okay.
So how does acute liver come? Present as? Okay, encephalopathy depends on severity. May not be severe enough to come as an...
Leading manifestation or...
No, hallmark. Hallmark of acute hepatocyte disease.
Jaundice.
Jaundice.
And can you not have, without jaundice, acute liver cell? Yes, Rice syndrome, acute metabolic liver disease. So why jaundice? Give a thought. I mean, as I said that here we don't want you to just pass MD. Even I passed MD. So what is so big for you? But we need to think something beyond. I'll give you a clue. How does an acute cardiac problem present?
Breathing difficult.
Breathlessness.
It has no time to show you edema. He comes in a shock. He comes in a cardiac failure. Okay, and that's a left-sided failure, acute cardiac failure. There is no edema there. There could be edema in the pulmonary circuit. So breathlessness, but no time for that. Therefore it's not. What about the acute liver? Again, no time for showing you edema, acute encephalopathy, acute hemorrhage, jaundice or no jaundice, but no time to demonstrate jaundice. What does it mean? That acute renal is not strictly acute renal, but a silent one going on and an acute manifestation. Okay, and that is how that proteinuria is not the cause of edema. One fine day proteinuria occurs, you don't get edema. Something is happening already before that, and then one fine day, the mother says, only this morning there is an edema. You get the point? Therefore that. Now which other edema can also be acute onset periorbital?
Fluid overload.
Okay.
Angioedema.
Angioneurotic edema. So could this be angioneurotic edema? Acute onset. Okay.
Trigger factor should be there. And it will not last for 4 days.
So it is not restricted only to periorbital. It could be the lip swelling, it could be anything else. And then my next question is, why is the renal is periorbital only, but an angioneurotic acute, but also lip edema somewhere ear, both are acute? One is restricted to
So the mechanisms for both are different. In angioneurotic edema, there is histamine release, which is generalized, so that causes swelling all over the body.
So the etiology is different. Okay, one is an allergic inflammatory edema, another is a problem with the sodium balance, right?
Acute orbital edema can be a serious manifestation of something else. Pardon me? Orbital cellulitis can be a serious manifestation of something else. Yes, cavernous, or more than that, ethmoid sinusitis, and it can be serious. Then why can't it be ethmoid sinusitis? Just now there's one patient being discharged tomorrow with ethmoid sinusitis. Acute periorbital edema of 4 days duration. Sick child. If no intervention, I was at stake. Pardon me?
Redness, pain, inflammation.
There is no pain, there is only edema. It was a sick child. There was no pain on pressure, there was no orbital pain. Because it is unilateral, it's not bilateral. Okay, the ethmoiditis usually affects one, the other may take time or may not get affected, so ethmoiditis. And also we mentioned that renal failure, the liver failure and heart failure take time. But renal failure, is this renal failure which is producing the problem? If all other take time, then the renal failure also should take time to develop. Heart failure takes time. This is also acute. Is this renal failure which gives rise to edema? If there was a renal failure, probably such an acute edema may not come immediately. So it is not renal failure, it is just protein loss that gives rise to edema. There is no involvement of... nephrotic can go on for weeks without producing any acute renal disease. So it is not a manifestation of renal failure, it's a manifestation of one disorder of kidney without an actual failure, while heart and liver will require organ failure.
I think the small difference is any painful inflammatory condition presents with pain and swelling. Second, it is always unilateral, not bilateral. So patient complain to say, I have a pain around the eyes, is his main complaint. And also swelling. Okay. And only one eye. Okay. But you can occasionally have a venous thrombosis, and a superior sagittal sinus thrombosis could also present with facial edema. Okay. So these are, yes, we keep in, but the point is, they are not one fine morning acute. They come up slowly, and that is where it is. So something that happens suddenly is unlikely inflammation, but usually a metabolic or immune, and therefore even an acute venous obstruction is not all of that acute, but over some hours or a day or two. Same thing about the orbital cellulitis. Besides being unilateral, it's not one fine day all of a sudden. Whereas all of a sudden is always metabolic or immune, and these are others infective or venous obstruction, but not acute onset. Really, it's few hours, like difference between embolism and thrombosis. Okay, both are acute. One is ultra acute, another is few hours.
There is bilateral edema of both upper eyelids. Bilateral. Over just 3 days. Child is not sick. As he mentioned, there is venous decongestion. A small abscess in the scalp lesion can easily produce bilateral edema, but only of the upper eyelids. That doesn't qualify for the definition of orbital puffiness. So make sure that when you talk of this, both the lower and the upper lids are involved. That means on both the sides. And here it's simple because the drainage of the lower lid does not go up, it goes lower down. So only the upper lymphatic drainage, upper lid lymphatic drainage is affected. So they are bilateral upper lid edema, relatively acute.
So this is one important learning point, that lower lid edema could be renal, upper and lower could be renal, but only upper lid edema is not renal. Okay? So this is something to learn. And then Dr. Anjali was asking on the net in the same line that which are the painful edemas of the face. So we discussed all this cellulitis and venous sinus thrombosis and all that, right? Okay. Now, in this child, so you said renal. Now, within the renal, any further narrowing down we can do based on this history, or you ask questions. So, is it glomerular, is it tubular, or is it the collecting system? How can you decide clinically?
Protein loss is mostly glomerular.
So do you get protein loss in tubular diseases? There's tubular proteinuria. Yes or no? There is.
Not
there is.
so large, not so much to cause edema.
So the molecular weight of those proteins is not so big, so they don't cause edema. So tubular proteinuria is only a biochemical. So this is glomerular. Within the glomerulus, can you further decide which part? So how do you divide clinically the parts of the glomerulus for clinical discussion? Yes? So one is the epithelial disease, one is the endothelial disease, and one is the interstitial disease. That's within the glomerulus. So example of endothelial glomerular disease is acute post-streptococcal glomerulonephritis, right? So can this be that? Or what questions you want to ask? So you're right, it's not. Why? Mask.
History of sore throat, any infection of upper respiratory tract.
So you're right, but see, these histories, take them in context. One is preceding history of sore throat can be very common, right? On the other side, suppose there is no preceding history of sore throat, it doesn't rule out if there are many other symptoms. So this kind of a history, whether it's for GBS, whether it's for PSGN, it's a small supporting history. Absence of a previous illness will not rule out GBS, right? So what is the other important, so what is again the hallmark of clinical presentation of post-streptococcal glomerulonephritis? Hematuria, right? So puffiness will be mild and hematuria is the main presentation, right? So how do you differentiate clinically between this, what we said, endothelial disease, and what is epithelial disease? Example, nephrotic syndrome. So how do you clinically differentiate between the two? On there, in endothelial disease, what else will be there? Hematuria, hypertension, oliguria, signs of renal dysfunction. And in epithelial disease, what else will be there?
Lipiduria.
Which is all biochemical. We are talking of clinical. So clinically,
Anasarka.
just edema. Which one will have more edema?
Nephrotic.
Epithelial disease will have more edema, right? So massive edema without any of those features, classically we are saying, is epithelial disease. And how do you pick up interstitial disease? Example of interstitial disease? Interstitial nephritis caused by, let's say, a drug, NSAID or whatever. How do you pick it up clinically? So what will be the hallmark symptom? Hematuria, but without signs of glomerular dysfunction. So no hypertension, no edema, no oliguria, etc. Right? Okay.
I think this is fundamental undergraduate difference. We should start knowing that. Okay. Why does the interstitium doesn't cause any other thing? Interstitium is between the glomerular cells. And when the interstitium is involved, there is a pressure on the glomerular capillaries, and therefore all that can happen is just not the function of the glomerulus is involved as much as a pressure causes some leakage of blood, and therefore only hematuria. This is classical difference. But now we are at a postgraduate level. So please remember that there is a tremendous overlap between all this. Because nothing stays only there for a while for you to pick up. After all, nephron itself is small in that all three layers are soaked together. But for our understanding, we have said that. So in an exam you would say, this is most likely nephritis, but probably a variety of an endothelial primary disease rather than a primary epithelial disease, because the nephrotic will also involve hematuria. Okay, and an endothelial disease may present with a little more edema than what we classically know. So those are not strictly the differences for you now. So you will not bank on that, but you would say that this child has had no hematuria, massive edema. So this is nephritis, more likely affection of the epithelium. However, I want to also rule out an extension of the disease to endothelium. And how do I do that? Microscopic hematuria, hypertension, so not a simple nephrotic, but something complicated. And why complicated? Epithelium is the primary site, but has gone on to endothelium also. Therefore, a combination. So today the nephrologists don't want us to differentiate these two clinically, but at our level, we should say mostly this, like hepatobiliary, mostly biliary, which became hepatic, or mostly hepatic, which became biliary. Okay, that's why we will say that. So there will be exception. And clinically you cannot be certain, so minimum investigation like knowing blood pressure, knowing microscopic examination of urine, albuminuria or otherwise, will decide possibly. And the best way would be to see 24 hours urine excretion. Then that only decide whether the primary focus was here or there. So keep that in mind. Otherwise, you might say we have been taught it is as simple as that. This is to begin with an understanding. But also now for us, tremendous overlap. Okay, so keep that in mind.
Also, you only asked about post-streptococcal. Often it is secondary to skin disease. Okay, it's not only the streptococci here. Many times pyoderma is a preceding event following which a nephritis, not nephritis, can develop. And occasionally a microscopic hematuria may not present as red colored urine, which is very obvious to the patient, but it may be just a smoky urine which can be easily missed. So presence of red urine will prove hematuria. Absence may not completely rule out unless you do a microscopy.
Okay, now there's a history of reduced urine output. So how do you decide that? Means that what I'm trying to say is, what in your mind is reduced urine output?
Frequency, how many times the child uses a washroom.
So what frequency is reduced and what frequency is normal? Do we have a fixed number for a fixed age?
No.
So how to decide? So simple, you ask them that every day or under normal circumstances how many times this child used to pass urine, and compared to that if there is an obvious reduction in frequency, then that. So more than frequency, you are referring to volume of urine. When you are saying reduced urine output, you are not referring to frequency. But to judge reduced volume, you will also have to ask about frequency, right? Okay. Now, why all this negative history, and tell us the logic behind it. Everyone. Not just Shiv Prasad who presented. So why do you want to ask for no history of fever, skin rash, joint pain and sore throat? Okay. So before that, if we say no history of hematuria, then is PSGS ruled out? No. So can we have PSGS who comes with edema of the eyes but no hematuria?
There may be microscopic hematuria which can be missed by the patient.
Then no history of increased frequency of urination, dysuria, hematuria. Why do you want to ask that?
To rule out any urinary tract infections.
So what is the relevance here? What I mean is, the chief presenting complaint is puffiness of eyes and decreased urine output. In this presenting complaint, why do you want to rule out a urine infection? This presenting complaint don't suggest a urine infection, no? So then why do you want to rule it out? So if at all, it could have been the trigger for the nephrotic syndrome in a subsequent episode, as in a relapse of the nephrotic syndrome. Then no history of breathlessness, cough or pedal edema. Sorry? To rule out cardiac. No history of jaundice, eye colored urine, hematemesis, blood transfusion.
Liver.
Liver. Why blood transfusion?
Hepatitis B is known to cause nephrotic syndrome. Could be
Secondary nephrotic syndrome. Okay. No history of not gaining weight, skin changes. No history of drug intake before onset of edema or insect bite. Okay. So actually we've always been telling and teaching you all that if you start your history by forcefully conveying that this child was absolutely alright prior to this episode and he or she suddenly developed this edema, then all these causes are automatically ruled out. You add one more thing, who has been growing normally till today. Okay, so now you had 2 episodes in the past also. So what do you think? This is what type of nephrotic syndrome? Based on this history, 2 episodes in a span of around 1 year. Steroid responsive. Okay. What do you think it would be the pathology? Minimal change or something else?
However, the first episode itself is not completely treated because he has received that oral medication for 6 weeks only. So that itself is an inadequately treated nephrotic, and then he has relapsed. So
He relapsed in how much time after the first one? Shiv Prasad? 7 months. So do you think that is because you'll call it inadequate treatment and this, or it was just a relapse? What I mean is, if somebody is inadequately treated, he should kind of start with his symptoms immediately, as soon as you stop the therapy. Whereas this happened after 7 months. So the question is, if you would have completed that treatment, would he have relapsed after a longer interval? That's a different issue, but ultimately it's a relapse, right? Okay. So
At that admission, child was given intravenous fluids. Why must it have been given? Do you give intravenous fluids to nephrotics which are admitted? Then why must it have been given? Yeah.
Intravascular volume, had it been less on presentation, then it is an indication for IV fluids in nephrotic.
Yeah, but you give intravenous fluids and it will leak out. And you will again get more edema. Oliguria may improve for a fraction of a second or may not improve. Well, you have corrected the intravascular volume, but for a very short time. But this is all going out. So maybe it may have to be associated with forced diuresis. Then that will be helpful. IV with Eilif furosemide or something. That is in case the patient is significantly hypovolemic, oliguric and yet edematous. And then fluid restriction etc. may not be feasible. So it's a relatively acute condition. And how do you diagnose that?
Signs
Because
of
it's edematous, so do you know how to dehydrated?
signs of shock like prolonged CRT, then pulse,
That is-
tachycardia.
Shock is little later. You want to treat him before he went in
Tachycardia.
shock. Pardon me? Tachycardia, hemoglobin.
abdomen also.
Okay, hemoconcentration, tachycardia.
Now, what was this pain and fever? Okay, look at that. Fever and pain while micturition. You think this is getting a complicated nephrotic syndrome? Where is pain while passing urine? Is that a symptom of nephrotic syndrome or nephritis? No. Then what is happening here? And the fever coming. Okay.
UTI.
Complication.
That could be the trigger for the relapse.
But in that case, the fever should have been first, and a day or two later, the aggravation or a trigger. Okay. It says that similar complaints of swelling associated with fever and pain. So, fever, pain, and swelling came together. So, how can fever and pain in a urinary infection have swelling? And how can swelling in nephritis have pain and fever? There's something amiss there. Don't you agree to this simple thinking? Then where do you relate that fever and pain in this child? Where is the anatomy of this pain while micturition? Where is the anatomy? Where does it localize to in a renal system?
Pain while urination is localized to lower urinary tract.
So now, lower urinary tract, can it be a complication of a glomerular disorder? No reason. Then why is that happening? And I think what we are trying to get is, get some more details of all this. Okay. Simply a little pain that he's talking about in micturition could be significant oliguria that this child has, fever on the top of it, further reduced intake, there is a blood flowing out sometime. So it's irritating the lower urinary tract, in the urethra. And that's why the pain could be coincidental. But how will we arrive at that? Only if you know. See, every symptom has to have ODP. Where is the origin of fever, duration of fever, progress of fever? Same thing about pain. If we do not ask ODP that you learned in the first clinical term in the second MBBS, it holds true even today. And unless we know that, okay, Obviously, this child received intravenous medication. That means somebody thinks about a serious infection. Where is the infection? Lower urinary tract. Then why it is serious? Why does it need intravenous medication and hospitalization? Okay. So again, when you don't think properly, you rush into something. Of course, we would have been happy to know how long was the hospitalization, how long intravenous medication. But I would not have even given intravenous medication. I might not have even given any antibiotic unless I thought there was some unrelated lower UTI. Okay, this is the male child.
Female child.
So female child might have had a lower urinary tract infection. Okay, and it may not need much of even antibiotic treatment. So all these details are required, right? Yeah.
Now, what in blood investigations in the second episode? So normally somebody comes with a relapse of nephrotic. What would you ask for? What investigations?
Protein create ratio.
Why protein create ratio?
Because it will specifically suggest if it is more than 2, then it is relapse.
Correct. So what is the importance? Suppose it is 3 plus or 4 plus. Then do you need to do protein create ratio? Urine routine is 3 plus or 4 plus. So it is large proteinuria. So why waste money of protein create ratio? Come on, who will answer that?
Urine protein creat ratio is a substitute of the 24-hour urine
Very
protein. So that spot urine will only tell you how much the proteinuria is at that time, whereas a PCR will tell you how much urine is being excreted. How much protein is being excreted in the urine throughout the day.
Right. So one is it will give a quantification number to that 3 plus 4 plus. So the point is one, just for understanding, somebody's urine 3 plus 4 plus could have a protein create ratio today of 10. And tomorrow or day after the protein create ratio will be 6, but it will still be 3 plus 4 plus. But 6 is better than 10, something like that. So one is the quantification. Secondly, the reverse is very important, that there would be occasions when your routine urine will show 1 plus, which you think is not significant, but the protein create ratio can be very high, right? So that is why you must always do a protein create ratio. As he said, it's a surrogate for 24-hour urinary protein excretion. What else will you do at the time of relapse? Other investigations? So means what I'm asking, we just, see nephrotic we've done so many times. So let's discuss some small other issues. So what blood investigations would you do in a relapse nephrotic?
Serum create and total protein with albumin.
Okay, why? How will it help? Serum create and total protein.
Just to rule out in case if there is pre-renal part of AKI during this phase, which is less likely but can be.
So for pre-renal part, create is important or something else?
Along with BUN.
Along with BUN. So what I'm trying to say is, and I'm sure you also all mean that for the relapse itself, you don't need any blood investigations. Your urine routine and your urine protein create ratio is good enough. At the most, if you are thinking of a UTI, then a urine culture. For relapse itself, you don't need. If you think there is any other complication that is setting in, child is too dehydrated or intravascular volume is low, etc., then you need other investigations, right? Okay.
Would you like to do C3 complement? Since he has a relapse, you would like to rule out a hypocomplementemia. A persistent hypocomplementemia might mean a different prognosis. If you do it in the early stage, then it may not have meaning because later on it may decrease. But persistence of low C3 and C4 may mean that we are likely to have more relapses.
Okay, you want to give us the summary?
A 3-year-old girl, fourth born out of third degree consensual marriage, who is developmentally normal, immunized till date, girl, child present with puffiness of face and reduced urine output for 4 days, with 2 similar illness in the past, with no significant family history. With the above history, I would like to think most probably renal disorder, probably nephrotic syndrome in view of the age and type of presentation. On general examination, the child is alert, active and febrile with pulse of 98 beats per minute and a respiratory rate
Child
of
is here. Child is here.
Yes.
Call the child.
With respiratory rate of 26 breaths per minute, with blood pressure of 90 by 60 mmHg in a sitting position, right upper limb, the peripheral pulses were felt, central pulses were felt with the extremities warm, and periorbital edema present but no pedal edema, and there is no pallor, icterus, clubbing or generalized lymphadenopathy or any cyanosis. Anthropometrically, the impression was normal. On head-to-toe examination, the periorbital puffiness was observed with no any dysmorphic faces. In skin, there is no rash, no lesions. In mouth, the oral cavity was normal with limb BCG scar were present, and in joint there is no swelling, tenderness, or deformity. With external genitalia were normal. On system.
Wait. Go back. Come on, someone volunteer to examine this child. Come on. Come, 2 volunteers, come here.
Without disturbing, let 1 or 2 come near and start talking. Don't even touch him. Okay, come. Come, somebody. Not difficult. Come. Who will accompany her? Come. Just go on talking. What you see, that's it. Don't even go near him and just go on talking. You could stay here so that he can focus on.
Child is sitting comfortably in the mother's lap, non-sick looking child, and on head-to-toe examination there is periorbital puffiness which is present. However, there is no other visible edema elsewhere, and there is आंटी उसका थोड़ा कपड़ा ऊपर करेंगे क्या? The abdomen also looks uniformly distended, and
there's a wrist widening, and otherwise wrist widening. Otherwise,
So if you see this child now, what's your probable diagnosis? I think he is a happy soul. He has no disease. Okay, he's so good. Okay, he's naturally a little worried what we are doing, but he's well grown. He has got a good muscle mass. He's not hypoproteinemic. He doesn't want to show his abdomen also. He's very conscious. Okay, he's a normal child. Don't you think he's normal?
the swelling would be more marked in the morning hours. The swelling reduces, as we know, during the evening hours.
Did you notice anything when he lifted his shirt?
Very good, very good. Good. First. Very good. Abhi chhod de. Very good. You're a good boy.
What did you notice? The umbilicus is normal? Slightly transversely stretched. So that is something that you have to observe.
So does it mean ascites? But his abdomen did not look big, but certainly the umbilicus was stretched. Why is that? Do you think he has an ascites today? We'll examine him, but unlikely. No clinical ascites. Then why the smiling umbilicus?
We can further examine in lying down position because she is sitting, it's looking like that.
This means there is a swelling of the abdominal wall. You can't show pitting, but there is a swelling of the abdominal wall, not ascites necessarily. Ascites will have also that, but will have flanks full, etc. So there is an evidence. What about his cheeks? And what about his little lower eyelids? There is still an evidence, okay, and therefore he still has an edema, not localized but generalized, okay. Now my next question is this edema due to his steroid? Steroid causes edema. So I want you to tell me whether this is a well-treated nephrotic or yet not fully treated nephrotic by only looking at him.
So what inspection feature or observation feature will tell you that he has been well treated?
Like if it was due to steroids, then Cushingoid facies would be more prominent.
And
Skin changes would also be there.
okay, for which you'll have to look inside. Even sitting you will come to know that this child is on steroids. Anything else besides the Cushingoid facies? Very good. Euphoric child. So, over happy. Okay, so that will also tell you that he is on steroids.
And normally, if you start steroids in a steroid responsive, edema is the first to disappear, even before steroid effects come up. Okay, steroid euphoria will come by about second week of life, second week of therapy. He has still edema. So he is certainly having a disease still. He is possibly recovering nephrotic, but not recovered nephrotic. Okay, how does a recovered nephrotic on a long-term steroid look like? No edema, but baggy cheeks, even little abdominal distension. Why abdominal distension? With a steroid therapy. Patient must know that edema has disappeared, but edema has come over the cheeks. So for a mother, all that you have done is, from here the edema has got over the cheeks. But cheeks is not pathological edema, it's a drug effect. Similarly abdomen. Sir, abdomen was very protuberant, it was less, but it is still big. So does the steroid therapy cause any space occupation in the abdomen? The answer is yes. The liver is often enlarged. Okay. And in an exam, you would see a treated nephrotic who has baggy cheeks but no periorbital edema, abdominal distension, and a liver which is just a little more than normal span, looking firmish. And an examiner asks you, why not a chronic liver disease? Firm, enlarged liver, and a history of edema.
And maybe mild ascites.
Yes. And mild ascites too, yet clinically. Typical chronic liver disease like cirrhosis. How do you rule out in exam that nephrotic? See, in exam, nephrotic will not come like this. He will come treated nephrotic. And treated nephrotic may look like cirrhosis superficially. How do you convince an examiner it's not cirrhosis?
Growth failure.
Excellent. Well-being, growth, no pedal edema, no chronicity, no splenomegaly. If there is an ascites, liver is failing. Then how can you have no jaundice? So many things. Okay, very good. Good. Now quickly examine for a 1 minute पेट देख लेते चलेगा ना? हाँ रोने का नहीं हाँ इधर आ जाओ. Just show us whether there is a fluid there. That's it. एक मिनट बेटा, कुछ नहीं करते. जी, आप भी उस तरफ आप भी उस तरफ. मम्मी आती है, देखो मम्मी आई ना, मम्मी आई. अभी कुछ नहीं करेंगे ना, खाली पेट देखेंगे, फिर निकल जाना. ओके, गुड बॉय. First inspection, then palpation.
On inspection, the abdomen is uniformly distended, and there are no visible dilated veins or scarce sinuses, and the abdomen moves uniformly with respiration. The umbilicus is also central and slightly everted. And then on palpation. On superficial palpation, there is no guarding, tenderness, or any rigidity. On deep palpation, there is no organomegaly. Then percussion for like free fluid. And on inspection, there is no flank fullness as well. On percussion, a tympanic note is heard throughout all the abdomen quadrants, and then auscultation for bowel sounds or any bruit.
So clinically there is no ascites.
Show us abdominal wall edema.
Actually, like with the bell of the stethoscope, if we try to put, then the impression.
In the
is-
absence of the stethoscope.
We can pull down the pants to see the
Very
elastic.
good, very good. So the markings of the trousers and all that. Yeah? Okay.
Can pinch abdominal wall, can pinch. You can just pinch the abdominal wall and release after some time, you will see the impression.
On abdominal examination, inspection, the abdomen is uniformly distended. Abdomen is uniformly distended, flanks are full, the umbilicus in inverted, transversely stretched and shifted down. With all quadrant moves equally with respiration, there is no scar, dilated vein or sinuses, and skin over the abdomen is normal. On palpation, the abdominal girth was 52 centimeter. On superficial palpation, abdomen was soft, no local rise of temperature, tenderness, guarding, or any rigidity. On deep palpation, liver was just palpable, with span of 6 centimeters. Spleen were not palpable. On percussion, there is resonant note throughout the abdomen with no shifting, dullness or fluid thrill. On auscultation, bowel sound was present, no bruits or any venous sum. On genital examination, they were normal. With cardiovascular systems were normal. With respiratory system, bilateral normal vesicular base, sounds heard equally. No added sounds. With central nervous system was conscious and oriented. With power, tone, reflexes were normal.
When liver is just palpable, do you want to look at the span? I thought enlarged liver you want to confirm with span. Here is just palpable liver. Do you think it's worth mentioning a span? Why? It's not enlarged. Then why span?
It will give us the true value of the.
Would it still be? The liver could be way up there and enlarged. And why should the liver be up there? There could be an eventration of diaphragm. There could be a diaphragmatic paralysis unrelated to this. Therefore, make a habit to talk about a span even when it is just palpable, just to be sure that. Of course, you would have known if you percuss the chest that why is there impaired node way up there. Okay. Should you percuss the chest in a nephrotic syndrome? Why should we do it? Liver span you must percuss. Any other reason? Pleural effusion. So you must, in other words, what about pericardial effusion? You have ascites, you have pleural effusion, pericardial effusion.
Mon, do you get pericardial effusion in nephrotic? Do you get pericardial effusion as a transudate? That's the question. So it's very uncommon to get pericardial
Why
effusion.
periorbital edema? The loose space. That's why first it fills. Okay, when it's large, where should it fill? Where there is a large space. So nature finds abdomen first. But that is not enough. Then which is another next? That is pleura. And pleura is also both sides. Even that is rare. So the nature will see that because of that collection, you are not in trouble. So generalized edema, you are not in trouble. Ascites, you are not in trouble. But if that is not enough space, then localized pleural, hopefully not trouble. But then when it will be bilateral and then there will be no choice but everywhere, that will not happen. That's why pericardial collection is always inflammatory, okay, not just transudative. Do you get ascites in a kwashiorkor? Severe hypoproteinemia? In a nephrotic, it is down to 1 gram maybe albumin, so massive ascites. In a liver, it's not so bad, maybe 2, 3, 2.5. Same way about protein malnutrition. Then should protein malnutrition also not have ascites? Both are hypoproteinemic. Liver also is 2.5, 3, borderline. Nephrotic, of course, way down.
In the child with nephrotic syndrome, the child may have the enough of the protein intake, but protein is getting excreted. That's why the child is getting edema. And in malnutrition, the intake is only less.
Good. So protein alone is never a cause of that edema, in nephrotic also. In a nephrotic, it's a sodium-potassium pump. Okay, in addition to hypoproteinemia. That's why massive. In liver, in addition to hypoproteinemia, portal hypertension. Therefore, largely ascites. In malnutrition, there is no such additional factor. And that is why ascites in kwashiorkor almost unknown. Okay. Because you need some more components to cause that. And I think that is why protein malnutrition should never cause an ascites by and large. Theoretically, yes, it's possible. Possibly Sheila Sherlock in her book might mention that, yes, she has seen once, but none of us will see. So, as a rule, and that's the reason why there is no ascites, right?
And clinically never. You may get it on a USG. So don't talk of that ascites in malnutrition. Okay, go ahead.
Diagnosis: 3-year-old girl, born out of third-degree consanguine marriage, developmentally normal, immunized, still dead girl, child present with a incidence onset and gradually progressive puffiness of face, followed by reduced immune output with significant two similar illness in the past, requiring hospitalization with no significant family history. On examination, she has a periorbital edema with no evidence of ascites. Probably this is a case of nephrotic syndrome with no complications. On investigation, the complete blood count shows the HB of 12.3 gram per deciliter with hemoconcentration of 40.8%, with WBC of 13,100, with lympho predominant 49 and neutro 45%, with platelets count of 310,000, with indices of 77.6, 23.3 and 30.1. The serum albumin was 2.8 gram per deciliter, which is low with the serum, so cholesterol was 416 milligram per deciliter, and triglyceride were 208 milligram per deciliter. The BUN was 8 and creat was 0.3 with serum electrolyte was 139.3.8, and urine protein were present in urine analysis. RBC were absent and pulses of 6 to 8. Then urine spot protein creat ratio was 18.25 milligram per deciliter with urine culture where no growth. And the Montauk test negative chest X-ray were within normal limit, and USG kidney urinary bladder were normal.
So how will you treat this child?
So, as it is a relapse, so we will go through the relapse regime with steroids for the till remission occurs. After that, alternative day, 40 milligram per meter square per day steroid prednisolone therapy till 6 weeks AD regime, alternate day regime.
He said he did man-to-end chest X-ray. I thought today tuberculosis you don't diagnose by man-to test. You agree to that? Why is he doing man-to test? I did man-to test 6 decades ago because we did not know what we are doing. Or at that time we thought we were doing right. So today we know man-to test has no place in diagnosis of TB. Should we do man-to test? If that is the statement that has been harped on us all the time, what is your comment on that? So is it justified? Or he just did everything? So in India you always do man-to test and chest X-ray. Okay. What do you think? Justified?
Come on, this means this basic should be clear now. So agreed no that you can't diagnose TB on the basis of man-to. Agreed or no?
To just rule out latent tuberculosis before we start the steroids.
You are right. In other words, you should have said, we must rule out that he is not infected. I am not bothered to know whether he is diseased. I want to make sure he is not infected. If he is not infected, I can go ahead and give steroids. So in nephrotic, we will do man-to only to say whether he is infected or not. Okay. But next question. It's an immunological disorder, nephrotic. And therefore, do you think man-to negative is a good evidence that there is no infection? And we are doing it before steroid therapy. In this child, you could have done it after steroid. Then I would say steroid has suppressed man-to reaction. So how are you sure that it is still not infected? So you should not give steroids. You will flare up TB.
So when will man-to be negative? In what kind of immunological disorders?
Cell-mediated immunity when it's affected.
Affected as in high or low?
Deficiency.
So immunodeficiency it will be negative. Nephrotic is not immunodeficiency. It's an immunological disorder, but no immunodeficiency.
And therefore you are losing antibodies or proteins or whatever protein related defense, not cell. So you're not greatly worried about it. Though the better way also to be make sure that there is no contact with TB. And what is contact? Every one of us is in contact. If you travel by the public transport with 100 people in, one of them has a TB. So what is contact? Come on, now this must be known. See, when patient is so simple to diagnose, questions are going to be difficult. So you opt for a neurodegenerative disorder. Not too many questions. Why? Even the examiner may not know what to ask. What the problem? Okay.
So how much exposure is required to call it a contact? Give some common sense idea. So 5 minutes, 1 minute, few hours. Okay, so this is homework now. Next time we want all of you to read up how many hours of exposure is required to call it a contact. Don't look at the up to date just now. Don't bring out your mobile.
So I think the contact history suggests that has there been any person in close contact in the family who has been diagnosed and may be fully treated in the last 2 years? That is called contact. Okay, and why 2 years? I thought moment you start treating a patient of TB, within 2 to 4 weeks, his bacilli start getting killed and he does not continue to be infectious, then why 2 years? That's too long. Do you think for 2 years he is likely to spread a disease? I thought within 4 weeks he becomes not infectious, thereafter he continues to be cured. And he is cured within 6 months of compliant therapy. Why do you have 2 years? And the reason is you are never cured of TB in spite of any best treatment. Few bacteria remain alive in your body and your immune system keeps them in control. And if for any reason your immune system goes down, like during adolescence, during pregnancy, during steroid therapy, that silent focus will reactivate. Therefore, you want to have a long period for him to allow reactivation, and if he doesn't, you hope that he is no more now having a disease bothering others. Okay, that's the reason.
And if he is tuberculized, then he is tuberculized today, but disease may take time. If he is tuberculized today, his body is going to fight. There will be a war between the body and the bacilli. And if I am tuberculized today, I am not going to be infected tomorrow. Maybe the disease, so you give a reasonable time that the disease may be silent. If it is silent, if he has managed the infection, tuberculization for 1.5 years or 2 years, then probably he has managed it well.
Dr. Palniraman has made a point. We were talking about ascites in malnutrition. So he said if there is genuine ascites in a child with malnutrition, think strongly of abdominal tuberculosis. That's his suggestion. Okay? Fine. Anything else on this child, or we move to the next case? Okay? So we move to the second case for today. Thank you, Shiv Prasad. Suraj is presenting the second case. Suraj is here, not here?
Yes, sir.
You've come already, okay.
Good evening, everyone. Myself, Dr. Suraj. I am second year resident. I am presenting a short case. 5 year, 1 month old female child, second by birth order, born out of third degree consecutive marriage, Muslim by religion and Khan by community, hailing from Balampur, UP, residing in Kurla, brought by mother with chief complaints of deformity of the lower legs since 3 years and abdominal distension since 2 years. Child was apparently alright till 3 years back when the parents noticed deformity of both the lower limbs in the form of bowing of the legs after the child started walking at the around of 2 years of age, which was gradually progressive. This was associated with the pain in both the lower limbs while walking. Mother also noticed abdominal distensions 2 years back, which was insidious in onset, progressive, associated with the abdominal pain, which is on and off once in 2 months, generalized, non-colicky, dull aching. The pain was self-resolving and no medication were taken for the same. There is no history of trauma to the lower limb spine, no history of seizure, tetanus, stridor. There is no history of angular stomatitis, killosis, bleeding gums, delayed indentation. No history of recurrent respiratory infection, diarrhea, greasy stools. No history of alopecia, no history of recurrent vomiting, polyuria, acidotic breathing. There is no history of any drug therapy, no history of dental abscess, no history of similar complaints in the family. There is no history of repeated fractures, no history of jaundice, bleeding manifestation. There is no history of Cox or Cox contact. No history of fever with chills, or there is no history of bleeding, repeated blood transfusion. Past history not significant. Treatment history, child didn't take any treatment, no supplement received. Family history not significant. On ANC history, injection TT taken not registered, no ANC scans done, no ANC visits done, no supplements taken, no ANC complications. Birth history wise, home delivery, full term vaginal delivery conducted by Dai, cord cut by the sterile blade, baby cried immediately after birth, no NICU stay, no neutral jaundice. Child is immunized till date. On developmental history, there is isolated gross motor delay. On dietary history, child is a calorie deficit of 611 kilocalorie and protein deficit of 8.64 gram per day. There is a significant dietary history like child is exclusively breastfed till 9 months of age, then was only given a formula milk for next 1 month in view of no breast milk, self-prescribed 2 teaspoon of 2 spoon in a half glass of a regular size glass 3 times a day. Then again he stopped in view of non-affordability. Then complementary feeding started from 10 months of age. Home cooked food and biscuits were given. And socioeconomic history. Family belongs to lower socioeconomic class according to modified Kupo-Swamy scale.
Okay, go back to your first slide. Oh yeah, second one. Okay, so what do you make out of this description? 5-year-old girl, right?
Yes, sir.
With deformity of legs noticed at 2 years of age, and which was progressive. So what are your thoughts?
Manifestation of rickets.
Okay. So rickets is a strong possibility. What kind of rickets? Nutritional rickets?
Nutritional.
Any other thoughts by anybody?
Scurvy can also be present, vitamin C deficiency, because it is associated with pain.
So will scurvy come with deformity of the legs? So pain, yes, but not deformity. So if the chief complaint is deformity, then scurvy is out. So it is rickets. Question is it nutritional rickets? So how will you debate or discuss that? When does typically nutritional rickets start? When should it show? After weaning. Okay. So rickets is linked to what? Growth. So when is the growth maximum?
First year.
In the first year. So rickets should typically be seen in the second half of the first year. Whether you see at 6 months, 9 months, 1 year, that is up to you, right? So that's the classic age of nutritional rickets. Okay. So this first thing, that if the deformity is seen after 2 years, at 2 years, the first thought process that is this nutritional, less likely to be nutritional. Now one might argue that it happened after the child started walking. What age did the child start walking?
2 years.
2 years, yeah. So now, will that, suppose that makes you think, oh, this could still be nutritional because they started walking late. Then what else will you ask or see which will tell you whether it's really nutritional or not? Because it should start much earlier if it is nutrition. So what else will be indicative that this has started earlier and not at 2 years? So the other,
Frontal bossing reached wide.
so other signs which you will see on examination, which will tell you that this is much antedated than 2 years, right? What else? Can it be renal?
Growth failure.
Okay, so you want to know whether the child is growing well. What else?
Swelling of the body in renal failure. Rickets will be a later presentation. No?
Swelling as in edema. So, are we sure that there should be edema when there is renal rickets? So, we just discussed in the previous case that edema in renal is which part of the kidney? Glomerulus. And rickets in renal is which part of the kidney? Tubules. So, there is no edema in renal rickets, right? Okay. So, what else? One is growth failure, to think of or not think of renal. What else? Polyuria. So, if you can get that history right, then when would be the onset again? So, usually it should be right from the beginning, right? So, then the child would not do well right from the beginning in terms of growth and all that. And it will be progressive, right?
I think bowing of the legs in an infant is normal. Okay. And mother observed it when he started walking. If you were on the first day when she came with this complaint at the age of 2 years, would you not have said, wait and watch, do nothing? Don't you agree? Many mothers bringing a 8-month or 10-month-old child is a bit worried about a little bowing of legs. And you tell her, don't worry, okay. This mother has noticed at 2 years, only because he started walking, at which time she realized it was bowing. How does it make suddenly rickets and disease? Would you not have sent her home and said, don't worry?
Abdominal distension is like a further progression of the manifestation of rickets.
How is abdominal distension related to rickets?
Tone of the abdominal muscles and all.
Yeah, but that is not a very strong point to tell you this is rickets, no? You could have various reasons for abdominal distension. What is the posture of a typically 2-year-old, 3-year-old child? It's a little lordotic, no? So you may even get a little abdomen prominent just because of that.
And the answer is, when the normal bowing starts disappearing over age, in fact at 2 years it is not even there. Okay, so no question, at 2 years when she complains of bowing, even before she knows it's progressive, you would have said that no, it's likely to be pathological, it's persistent. So that is pathological. My next question is, if it's pathological, why is it not any chondrodystrophy? This child is an achondroplasia, nothing more. He looks like rickets, he is an achondroplasic or any other chondrodystrophy. Why? You could say, don't worry, now he is born like that. It's okay, do nothing. So why did you rush in to say rickets only? To me it's any chondrodystrophy.
Bone deformity will be noticed just after birth and not at 2 years.
And chondrodystrophy is something that you are born with. There is no reason why somebody suddenly comes and says, my child has this. So this is an acquired disease at the growing bone ends. Therefore we call it rickets. Okay, now we have started walking late. So rickets must have started early. So my first diagnosis is a nutritional rickets. Started early, got worse, was not taken care of, and now he presents at 2 years. The commonest cause is the nutritional rickets. So to me it's a nutritional rickets. Can you rule it out? She observed it at 2 years. Okay, when he started walking. But why did he start walking late? That means it must have started early. And if he started early, it was nutritional.
Till when does nutritional rickets progress?
If vitamin D deficiency is progressing, rickets progress. Don't you have anemia progressing and coming at 4 years, 6 years, 8 years? Progressive nutritional deficiency, no? So where is the problem? If iron deficiency anemia is seen at any age, which could have started at any age earlier, rickets is same. Don't you agree with me? I've given you sufficient clinical evidence of anemia, isn't it? Yeah. Now go against all this statement logically. And the reason is, if rickets persists because of no treatment, the growth stops and the requirement of vitamin D also stops, and therefore you don't have a progressive nutritional rickets. Nature says that your doctor doesn't understand, you will stop growing. And nutritional rickets is a disease of a growing bones. So nature stops growth and rickets does not progress. Even with vitamin D deficiency progresses or persists. Not so with anemia. Therefore this is not nutritional and therefore it's pathological. Now next is abdominal distension. Hepatic rickets, classical abdominal distension. Or if you like, the renal polycystic disease, the renomegaly, also often hepatomegaly and a polycystic disease, polycystic liver, polycystic kidney, and you have an abdominal distension. So to me it's a hepatic and or renal rickets or a hepatorenal rickets.
So arguments against hepatic? When do you know, what do you know of hepatic rickets? Which condition it happens, when it happens?
Your answer would be, I recall having read once in a while, okay, but I have never seen, my teachers have never seen, and the reason is the liver disease chronic worsening does not last to show you rickets. Much before that he has gone or he has got better. Hepatic rickets almost is not seen. But that's not true with renal rickets. So if hepatic rickets doesn't occur because hepatic functions go down much before even rickets can manifest, why is it not the same with renal rickets? Renal also should have been the same, no? And you have 2 kidneys. Where is the problem? Only 1 liver, no hepatic rickets. Okay, 2 kidneys and even then renal rickets. And the reason is there is a selective renal tubular disorder. When we are talking about a liver, it's a generalized liver dysfunction. Everything is gone. He would go down fast. But a renal rickets is a selective renal tubular disorder. Glomerular are all right. Many other tubular functions are all right. But a specific selective, therefore, all that is happening is he's not growing. But his kidneys are still surviving his life. That's why it's the renal rickets. Of course, most common, etc. Okay. Now what type of renal rickets? You can go that far.
What about the pain in the limbs? What do you think? How do you relate it to rickets? Any thoughts on that? Fractures, of course, it will be an acute traumatic event. This is in both lower limbs. So you can't have fractures on both sides. Na? And in routine rickets, you don't get fractures unless it's very severely osteoporotic. Osteopenia, okay, but theoretically yes, but actually, so rickets is also classified as hypocalcemic and hypophosphatemic, and one of them is associated with muscle pains, right? Which one? Hypocalcemic. I'm getting confused, but I thought it was hypophosphatemic. Hypophosphatemic rickets is associated with muscle pains, right? So it just gives you a clue if there is rickets and pains that you think this could be hypophosphatemic.
And do you have hypocalcemic rickets at all? Deficiency of calcium, can it cause rickets? Or if you do nutritional rickets biochemistry, do you get hypocalcemia? Normal calcium, but phosphorus will be low. Okay. So theoretically, hypocalcemia nutritional also may cause rickets, but for all practical purposes, it has to be accompanied with vitamin D as well, which does not allow calcium to be absorbed. And therefore that, and to that extent, biochemistry of a normal nutritional rickets is a normal or slightly low, if at all, calcium, but phosphorus is low, right?
Come.
So my impression is 5-year-old female child is second by birth order, born out of third-degree consanguineous marriage, brought by mother, with complaints of bowing of legs since 3 years and abdomen distension since 2 years, with poor dietary intake, developmentally isolated gross motor delay, immunized till date, belongs to lower socioeconomic class, is most probably a case of nutritional rickets, vitamin D dependent rickets type 1 or 2, or hypophosphatic rickets.
I think again, when you are asked for differential diagnosis, don't give all causes of rickets. Here there is no reason to mention nutritional rickets. Okay, we should be very firm and say, no, this is not nutritional rickets. And then talk about it. We are not giving all causes of rickets, we are giving a probable causes of rickets in this child. And therefore nutritional is out.
Maximum growth occurs in first 2 years of life, and minimum chances of getting vitamin D are also in the first 2 years of life. So if anybody gets nutritional disorder, the maximum chances is they'll get it in infancy or first 2 years. This child rickets started presenting at 2 years, and the word progressive is very important. The progressive retest tells you that this is a metabolic disease. Over a period of time, the metabolic abnormalities have increased. So some rickets may occur in infancy and may present at 2 years as with signs of increase, but with time it will not progress. When the growth is minimum and chances of getting vitamin D have increased much. So a progressive rickets is a metabolic disease because the metabolic abnormalities have accumulated over a long period. So then you have to think of which metabolic disease is likely to be.
Again, history-wise, you said progressive abdominal distension. Why is progressive? Okay. So again, get all the details of it. It's unlikely progressive. There is no space occupation expected in this child. And if it is really so, then you have something which is swollen inside, which could be liver or kidney in this child, or could be both. And as I said, one possibility is whether there is a polycystic disease of the kidney and the liver, etc. So we need to be very sure about that abdominal distension, because you said it's progressive. What does it progressive mean? How long progressive? So that is important. Again, point that we are making is spend details of history taking. That is very, very important. Otherwise, we will know finally with all tests, no? Why discuss all this? Okay, or best way, refer to a metabolic specialist or a renal specialist. That is simple way. Okay, but what are we learning? So we are not learning just to pass MD. That is guaranteed. Nobody has left without passing MD. Okay, but many have left without knowing medicine. And here we are trying to know medicine. Passing is guaranteed. What does it mean? You don't have to know too much to pass, but you need to have too much knowledge to practice. And tomorrow you are going to practice, or you are going to teach. So you must know the basics, then only you can practice well and teach well. And I think that's what you start learning, right? Get details of it. At your age, details of history taking and details of examination. Minimum, before you start thinking, right? Fine. So now, who will debate between these possibilities? He said the VDDR type or a hypophosphatemic type. Okay.
So nutritional we already discussed. Now, vitamin D dependent rickets.
So
what are your
what
thoughts?
type of history can possibly suggest the vitamin D dependent rickets? That's the question. Okay. And the only way you can know is that, does he get better in between when he gets vitamin D partially? And it's not easy to pick up this. But if at all the vitamin D dependent rickets comes with a seizure, hypocalcemic seizure, then he would say, oh, he gets seizures once in 3-6 months and he has a recurrent hypocalcemia. Then that recurrent hypocalcemia is treated temporarily by vitamin D, but after the vitamin D is discontinued or not adequately given, he gets hypocalcemic seizure again. So here we are not very, very sure. And we could be either of the two, and I think it's only the biochemistry that could pick us up that. If they are sure that it was starting at 2 or 3 years of age and never before, which means the story was he was gaining milestones, standing, walking in time, then we would have said it started at 2 or 3 years of age, and that's how typically a hypophosphatemic ricket starts at that age. So these are the small differences we can make, but for which we need to have a detailed history of that. Yeah? Let's see whether you have done some tests.
Yeah, on examination. You have the child here?
Yes.
Bring the child also.
On general examination of euthermic, pulse rate was 120 per minute, bounding, normal, tension force present at all the peripheral sites, no radial or radiofemoral delay. Respiratory was 30 per minute, regular, thoraco-abdominal type, no signs of respiratory distress. Saturation was 99% on room air. Blood pressure was 92/58 millimeter of mercury, taken in supine position on right arm. Extremities warm. There is severe pallor. There is no icterus, edema, lymphadenopathy, clubbing or cyanosis.
Why bounding pulse?
I think you have got a diagnosis of a chronic disease, kidney, because there is a severe pallor. Severe pallor is kidney, correct? You got a diagnosis. What's your comment? Chronic renal disease is anemia and severe. So that's enough to say chronic liver disease. बेंजी यहाँ ले आएंगे 2 मिनट.
So is there something on
यहाँ
this
बैठिए,
slide
यहाँ
which is against chronic renal disease? Hypertension. Okay, you wanted hypertension. Anything else?
Breathing. There is an acidotic type of breathing.
Very good. So there should have been acidotic breathing if it was renal rickets. Okay? Okay. Chalo, come. Some volunteers now. Come, you all want to come? Anyone? You'll come 2 or 3 so we can easily discuss. Come, Manas. Come. Anyone else from there? Chalo now, come. Nobody is coming, so come.
So, child is lying comfortably in mother's lap. On general examination, there is frontal bossing, malar prominence. Then can see widening of both the wrists and also the malleoli.
Okay, what about growth? What about growth of the child?
For 5 years, the height looks small.
Average. Okay.
Less to average.
And does she look sick or comfortable?
She's
She's quite comfortable.
Comfortable. Is she tachypnic, acidotic?
Slightly tachypnic.
Okay. I think she's quite okay. She doesn't look acidotic for sure. Okay, now go ahead and.
When do you think, looking at the baby, that rickets started in this child? We were told it started at 2 years or so, whatever. What is your guess, looking at the baby, when did the rickets start?
And why?
I'll give you a clue. In a typical rickets, which part of the body first shows visible signs of rickets, then following that, which other part also shows, and then finally, which part also shows everywhere?
Which part does maximally in the first 6 months?
The head,
Skull.
frontal bossing.
So the hair changes come in the beginning and are very prominent when the rickets have begun in infancy. Now if the rickets have become later on, the hair changes are not as prominent and the limb changes may be more prominent.
So you got a very wide wrist which can be seen right from a distance. So when does that happen? As soon as the child starts propping. So forward propping is at literally 5 months of age. So 5-6 months of age this rickets could have started, right? So that history that it started after the age of 2 years misled us, means that's what they thought, but that was not the actual case. Now you see, you know this started much earlier.
Only thing that you look carefully, there is some frontal bossing as well, but proportionately the signs are far more in the rest of the limbs as compared to the skull. So possibly in the first 6 months there may not have been much of a problem, but it started thereafter. But certainly it started also when the child was kind of putting the palms over the bed, and therefore it must have started in the later half of first year. Okay. Which may be another way to look at that. A nutritional ricket in a growing child without supplementation could have started even much early at 3 months of age. And if it was a preterm baby, would have started even earlier than that. So these are the ways to kind of guess of that, right? Does she look very pale, and does she have...
No, I just wanted them to take up these signs, the camera people.
Yeah.
इधर से आके उधर बिठा दो, इधर से आओ, ऊपर आओ.
चलती है बहन जी, चलती है.
इधर गद्दे पे बिठा दो.
She's walking with a waddling gait, I think.
बस इस पे examine and show the signs with your hands. Mic पकड़ो.
Frontal bossing.
She looks like a 5-year-old.
She's short.
Upper segment, lower segment looks proportionate, disproportionate. If she is dwarf, she's short-limbed dwarf or short-tongued
The
dwarf?
upper segment is more than the lower segment. And there's widening of wrists, abdominal distension, bowing of legs, and double malleoli.
Look at the abdominal organomegaly.
The abdomen is distended. There's no organomegaly, sir.
Beading, costochondral.
Beading is also there. They are rounded and non-tender.
Harrison sulcus.
Harrison sulcus.
In this one, what did you want to show? ठीक है. There's a firm hepatomegaly.
If you see on inspection, the umbilicus is way down. Look at the distance between xiphisternum and umbilicus. Almost 3 times the difference between umbilicus and the pubis. There has to be an upper abdominal occupation somewhere. Okay. Now, how can you miss a large firm liver? Even this should have told you that there is minimally a hepatomegaly, maybe something beyond. Okay. And now again palpate it and say, what kind of hepatomegaly is that? Can you make a guesswork? What kind of pathology must have given to this kind of an enlarged liver? And whether 2 things are related. Okay, that's the next step.
Sir, we need to see the spine also. If there is any spinal problem, there can be abdominal protuberance. Let us sit and see whether the spine is good or there is kyphosis. That can explain the protuberant and not really good spine. The spine is good and straight.
Meanwhile, give a thought. Liver 3 centimeters palpable firm, span 6 centimeters. Okay. Now let them finish and then I will ask you to comment on that. Is it an enlarged liver or not an enlarged liver? If it's not enlarged, then why is it firm and why is it so much palpable in the abdomen? So give a thought to that. Let them finish. It's something unusual, right? Yeah. Thank you. Thank you.
Yeah, you answering sir's question?
The growth of the thoracic cage has been affected, so the thoracic diameter is less in comparison to the abdominal diameter, and the liver has been pushed downward. I don't think it's a true hepatomegaly.
Yeah. You want to say something? No, so in this rickets, the organum, that's called visceroptosis. So the organs do come down and you would have a span normal, but this liver is quite firm actually. That's the problem. She missed it because it is so firm. She actually thought that was the edge of the costal margin. It is that firm. So that was her mistake. So basically it's abnormal liver.
So I think the only way you can explain is a very firm liver is an abnormal liver. It's not just little down there, but the size is not so much. Now what does that really mean? Okay, when does the liver become small? Only in a later stage of a chronic liver disease, and this is not a later stage. Then which other condition the organs, not only the liver, but every organ could look a little small, or I will use the word for simplicity, atrophic. If you look at a severe marasmus, the heart is small, atrophic muscles. Okay, every organ could be atrophic. And does it mean that there has been a failure? That's one. Second is there any other reason for this chronic thing? For example, if she has got not bad calories but too low protein intake, then it becomes a protein malnutrition, and the liver could be a fatty liver, and we are looking at fatty liver which looks firm, though fatty liver may not be very firm, but then a combination of all this. But this is certainly not a chronic shrunken liver which is firm, and therefore this is multifactorial liver. The question is this liver also causing contribution to the rickets? As we discussed, probably not, but we will have to closely look at what's the liver function like, and therefore we will mention there is no edema. If there is no edema, the protein should be reasonably all right, albumin has not gone down, there is no other sickness except the growth, and therefore it's unlikely a chronic liver dysfunction. And if that is so, then this is a structural changes in the liver without functional component disturbed, and that could be a fatty liver. Okay, that could be any. Then the next question is, what's the difference between fibrosis and cirrhosis? After all, both are firm. Is this a child with a fibrosis, hepatic fibrosis, and not cirrhosis? We said this is not a chronic liver disease, but can it be hepatic fibrosis? So what do you know about hepatic fibrosis? I'm sure once we have discussed in this Thursday clinic itself.
So in which one will liver function be affected? Cirrhosis. And what will the fibrosis lead to? Portal hypertension. What kind of pre-hepatic sinusoid, pre-sinusoidal, sinusoidal or post-sinusoidal? So typically you see extrahepatic portal hypertension, EHPVO, which you talk of. Do they have a liver enlargement? They have only a spleen. So in hepatic fibrosis, you have a liver enlargement and a spleen and portal hypertension.
And therefore, hepatic fibrosis, congenital hepatic fibrosis, is a pre-sinusoidal intrahepatic portal hypertension. Most of our pre-sinusoidal portal hypertension are outside the liver, but there is one variety where a pre-sinusoidal is because of the intrahepatic sinusoids block, and that is called a hepatic fibrosis. It does not upset the hepatocyte function until late, but it looks like a cirrhosis. It has a portal hypertension, it has a big spleen, It has a liver which is not so big, but certainly firm, with a normal liver functions. Okay. And it may also cause hematemesis because of a portal hypertension. And when hematemesis occurs, the borderline normal hepatic function in a congenital hepatic fibrosis becomes manifest, and you may see in such a child with a hematemesis presenting to you with a mild jaundice, and you will then say, oh, it's a hepatocyte disease. But the jaundice is extremely small, there is no ascites. If it was a sinusoidal portal hypertension with cirrhosis, with jaundice, it's a later stage of cirrhosis. You would have ascites also. A pre-sinusoidal portal hypertension does not have ascites. So if such a child presented to you with mild icterus, you would still feel this must have been a temporary aggravation of a borderline hepatic functions which got transiently abnormal, and wait for a while, they will come back to normal. So they are potentially likely to get aggravated with large hematemesis. So the question is this that? But the answer is no, because it would have presented with a big spleen. So this is not a fibrosis. Now what is the difference between fibrosis and cirrhosis? Both are fibrotic condition. No, there is fibrosis in cirrhosis also. Then what is the difference?
Cirrhosis is hepatocyte dysfunction, whereas fibrosis is interstitium.
So, in other words, cirrhosis is fibrosis plus.
Plus what?
Okay, anything else? Pathologically?
Destruction, fibrosis, and regeneration is cirrhosis.
Pseudo-lobular
In hepatic
formation.
fibrosis, there is no regeneration. That is cirrhosis. Okay. And therefore, this child doesn't look like that. Obviously, no spleen at all. So this must be multifactorial. We don't know what all are factors, but we will have to really look at closely. And I would anticipate near normal liver functions, but maybe some enzymes could be a little high. If enzymes are a little high, that means the liver is getting damaged, but we do not know why. Like a fatty liver will come with some SGOT, SGPT high, but bilirubin is all right, proteins are okay. So that kind of a problem, we will have to investigate the liver. Any test done?
On complete blood picture, a count of 11,000, hemoglobin of 4, hemoglobin of 4, hematocrit of 16.9, platelets of 2,29,000. On PS, it is microscopic hypochromic anesthetic RBC is present. And all routine. The liver function is OTPT is 85/30. Serum alkaline phosphatase is 1069. Total protein 5.9. Albumin 2.9. And RFT within a normal limits. Then serum calcium of 7.8. Serum phosphorus is 3.2. And iron profile study, the serum iron is 18, ferritin is 4, iron binding protein is 208, serum vitamin B12 is 279, and vitamin D, total vitamin D3 is 66.
Show that previous slide, yeah. Vitamin D shows that. Stay put. So what is your final diagnosis?
Nutritional.
Okay. So if it is nutritional, then why is the vitamin D normal?
In fact, little
Higher
increased.
range of normal. nutritional you expect it to be low, no?
Yes, sir.
Yeah. Okay. You done urine routine and all that, that is normal?
No, not done, sir.
Not done. Okay. Parathyroid hormone you've done?
Sent, yet to be traced.
Okay.
Done?
Sent yet to receive the report. Fine. So, I mean, if vitamin D's level is normal, then one possibility is vitamin D resistant rickets. But for that, you'll have to check both the 25 and the 125 levels and then decide. So, this is the 25 level. So, 125 you'll have to check and then decide whether it's resistant.
Absolutely. The 25 has to get converted into 125, and that further has to be converted into an active ingredient. So one takes place in the liver, the other takes place in the kidney. And if the further conversion is not taking, this child has active rickets. And further, so you expect a low vitamin D, but you have a high vitamin D because further conversion is not taking place. That is why the previous levels are high. So 25 to 125 is not happening. So 25 is high. So if you do 125, it's likely to be low. And if 125 is also high, then the further...
Then it means resistant, matlab type 2.
That's right.
Yeah.
That means even the conversion from 125 to active ingredient is affected. And therefore you will have to give the in one, if you give higher doses, then the conversion will be, so to say, partially effective. So that is why the initial diagnosis of VDDR and VDR type 1 and type 2 you have. Why is the phosphorus serum calcium low is little uncommon in vitamin D. In excess hypocalcemic rickets, which are quite different, because no sooner the calcium starts going down, the parathyroid hormone comes into action. And parathyroid hormone will do whatever it wants. It will remove the calcium from the bone, will maintain the serum calcium. But serum calcium is low means parathyroid is not doing its job well. Also, hyperparathyroidism should have produced a low phosphorus because parathyroid gives rise to phosphaturia. So here, what
this is on the lower side.
It is on the lower side. So I think it should be one of those VDDR. Hypophosphatemic rickets, usually they have a problem with the spine. And you take the spine and also take the spine of the X-ray of the mother and all, they may have that. So most probably one of those VDDR type 1, type 2. You'll have to read the details.
And as we discussed in the beginning, see, you said, and it is obvious that the rickets is progressive. So nutritional rickets would not have progressed till 5 years of age. So that is why, for all these reasons, it's not likely to be nutritional.
And I think in any chronic long-term progressive rickets, you would have the parathyroid getting tired, getting depleted, not much of parathormone coming up, and they are also likely to throw up a hypocalcemic seizure. But when you give vitamin D for a while, possibly the calcium goes up a little, whatever is there, and again it falls back. So that alone does not matter. In fact, in rickets, you rarely require to do vitamin D levels because it's only low in nutritional. Everywhere it is not low. But when you suspect something, you would rather do both. Not only the 25 OH, but also 125 OH. Then only you can interpret what is correctly, right? Good.
So could we get such a picture if the patient had been treated with vitamin D recently?
If the patient has received vitamin D recently, would you get this level? So the point is that even the calcium and phosphorus both being low don't fit in. And if he has received vitamin D, immediately the calcium should normalize. So I don't think that this is because of receipt.
If he has received vitamin D, whatever dose, in fact, that's why the vitamin D is high. Further conversion is not taking place. So unless you give vitamin D in high doses, some effective conversion is taking place. Suppose one part is converted into one part. Here 5 parts will be converted. So you give higher vitamin doses, then the vitamin 125 will come up and then your rickets will start healing. So presence of high 25 definitely tells you that there is a further block, therefore there is a previous accumulation. So vitamin D would give rise to some rise, but then you should see some increase in the 125 also. So this is certainly vitamin D, VDDR, type 1, type 2, we'll have to see whether further conversion is happening. Is it RTA? Or otherwise renal tubular rickets? Or this is renal rickets, the kidney is completely damaged and cannot convert it into the final product. In that case, the creatinine would have been very high and the RTA would give rise to failure to thrive. This child would have had metabolism. This is a well-grown child, reasonably well-grown. So that RTA giving rise to vitamin D, that part is not. So 99% it is conversion from 25 to 125 which is affected.
Dr. Palni has suggested that celiac to be ruled out, celiac disease. But I thought the rickets is too florid for it to be secondary to celiac.
Celiac should produce other nutritional problems also. This child's nutritional problem is not there. Rarely we have seen Wilson's disease presenting as rickets, but that is all, the Wilson's manifestations are more prominent and rickets comes up a little later, and that is because the damaged kidney retains phosphorus and then the phosphorus gives rise to, so that's all not seen here.
And that's it, no? You don't have anything else on this child. So next time let us know what is the diagnosis that comes up, yeah? After you get more investigations done. Chalo. So we end the class here today. So thank you all of you. Thank you all students who are watching online, and thank you faculty online. And we meet once again next Thursday at 6 p.m. Thank you.
Just you should be able to explain the radiological changes also of the rickets, the cupping and all that you know, but they will ask why cupping, why flaring, and if you start treating, the white line will appear. Where will the white line appear? Near the epiphysis or near the metaphysis? So all these things, radiological changes, you should know because they'll ask you.